Hello, everyone. Thank you all for joining us on this Friday afternoon for our May 2023 DEI session on mental health awareness. I wanted to take this opportunity to just remind everyone, if they are not part of our panel, to mute themselves. So that way we don't have any unnecessary distractions during the call. And then also to thank our sponsor, the Alabama Power Foundation, for supporting our DEI work. This session and all of our DEI sessions are a partnership between United Way of Southwest Alabama and the South Alabama Coalition of Nonprofits. And so together, collectively, we plan and recruit participants and share this information to our community and our region. So to go ahead and get started, I want to introduce our panelists and our facilitator for today's call and let them kind of just go ahead and dive in. So first off, we have Kat Loveless. She's the SANE coordinator from Lifelines Counseling Service, and she's one of our panelists today. And then also we have Dr. Jeremy Fletcher. He's the Chief Operations Officer at Veterans Recovery Resource. And then we have Miss Ida Lockett. She's an advocate and one of the many smiling faces that you will see at our local NAMI chapter. And I'm going to mute somebody real quick. And then last but not least, our facilitator, Ms. Cher Graham. She is the co-director of the Gulf Coast Mental Health Coalition and also the CEO of One Stop Business Institute located in Mobile. So thank you all for being here today. And Cher, I'm going to turn it over to you.
Good afternoon, everyone. I am Cher Graham. I'm the co-director. And Trista, we couldn't hear you because when you go to the side, your voice leaves the phone, leaves here. But I am the co-director of the Gulf Coast Mental Health Coalition, and I am very honored to be facilitating the mental health awareness panel discussion today. Housekeeping, please make sure that you are on mute if you're not part of the panel. If you have any questions, please put them in chat, and Trista will monitor them. Some of them we may get to at the end if it's very critical or important to the topic. She will break in and we will have a short discussion. The three topic areas we're going to talk about with mental health today are trauma-informed care, advocacy, and mental health access. As defined by, so now we'll get into the discussion. Our first question is, as defined by the Substance Abuse and Mental Health Services Administration, we know as SAMHSA, trauma-informed care is an approach that accomplishes the need to understand a patient's life experiences so that you can deliver proper and effective care to improve patient engagement and health outcomes. I want to start off this conversation. Kat, how does your agency define trauma-informed care as it relates to the community you serve? And then the other panelists, please fill in at any time. Kat?
So I think for Lifelines, we really try almost like a lens of just the way that we view, the way that we not only operate with our survivors, any of our clients that come into care, we really like to put them in the middle and figure out how, me as a medical provider can give them care that centers around them and not necessarily what I would choose to do, but how our plan can kind of improve life for them in a specific way that's going to be more effective for them. So I think overall Lifelines really takes advocacy, not only with direct patient care and direct client care, but throughout the entire agency to figure out how we can best serve, because that's the whole goal of this is for us to serve the community. So if we don't take an internal look at how we can be best trauma-informed care with each other, we can't really do that for the patients that we serve.
I think that is a very positive comment, and it is so true. if you're not at 100%, it's really hard on a given day to take and give back to the people you serve that 100% when your own level of self-care is not there. Jeremy, Ida, how does it impact your agency, or how did, with what you do on a daily basis in terms of the community you serve?
Well, NAMI, as you all, I hope, are aware, is the National Alliance on Mental Illness, the largest grassroots mental health organization for individuals and families who are affected by mental illness. All our educational programs are evidence-based, meaning that they are peer-driven. Our educational courses like basics, family to family, in our own voice, are based on the person's experience. As you know, trauma is based on the lived experience of the individual, and that could be from their wealth of knowledge, how they interpret the event, the traumatic event. And so you want to make sure that you're meeting the person where they are. NAMI, we believe in the recovery process, and our goal is to empower the person so that they can have hope and better learn about how to navigate the mental health crisis.
I think that's a very, again, another example of positive trauma-informed care approach. And you talked about two things: that you meet the person you serve or the family where they are. And the key word is not just getting them engaged, but empower them. Empower the family, the individual, to become more aware of what they need to help with their mental illness or just everyday mental health.
Right.
Jeremy,
Education is very key.
Absolutely. And I think if we don't learn something every day, just in our daily lives, then our own mental health suffers, because mental health can be anything from I lost my car keys, can't find them, and I spend 15 minutes or an hour looking for them, and they show up because they were right where they were, to having a clinically diagnosed mental illness. So it's such a large gamut, and we all serve in so many different ways. Jeremy, how does VRR look at trauma-informed care when you are serving your veterans and families?
Thanks, Cher. So I guess I can take a step back to 2017, whenever we first began. I think I saw that Trista dropped a few links in there, and I wanted to bring those into this discussion today because we've got a pretty good, robust set of experts in our area in this area of trauma-informed care, and VRR utilized their expertise in order to develop an organizational assessment for trauma-informed care for our organization. And so we knew it was important. We knew we wanted to incorporate the principles of trauma-informed care in our organization, and felt like we needed to assess ourselves and our ability to do so. So we reached out to Dr. Candace Selwyn at the University of South Alabama, and she conducted an assessment for us. So then based on that assessment, we began to implement the principles of safety, trustworthiness, peer support, collaboration and mutuality, empowerment and choice, and then addressing cultural, historic, and gender issues for those people who are seeking our services. So I think the thing that we really do well within our organization, and I recently saw Peer was featured on Mobille's Chamber's website, but it's a very exciting time. But I think one of the things that we do really well is our peer support specialists. They really, I feel like they do a really great job of encompassing all of the principles of trauma-informed care.
I think you mentioned something. If every organization would take that approach to assess the healthiness of their organization, we would find and take it with a positive approach and not see it as, oh, someone's coming in and they're going to find all of our negatives. Well, when you can identify the challenges that your company has culturally, whatever area, just even on a hi, how are you, daily basis, do you smile? It makes a world of difference in the health of that company and the health of the employees, the mental health, not just the mental health, but the overall healthiness of that corporate culture. Ida?
And Sherry, you're so right, because when a person is, you don't want to re-traumatize. So you have to make sure that the what you're trying to do is that you're strength-based, that you're from the time that from the time that you greet them throughout all the staff that's within your organization. And that you're empowering them to make choices so that they can buy more into what you're trying to help them to achieve. Because if we keep dictating to them, well, you need this based on what your organization can provide, you're not giving them choice. And so you're re-traumatizing, re-victimizing them.
And how many times do we walk into a business environment, whether it's retail, a restaurant, a hospital, and the first person that we contact, I mean, it's as simple as that. How do they greet us? What do they say? Do they smile when they see you? All of that plays into the health, our own mental health, because I know there are times, and I'll comment just, I try to sidebar it, but then I always get heard. Well, that person's not happy today, or wow, something's going on. They're not really friendly. And then I make that choice. Do I want to continue to do business? Do I want them as part of my life? And I'm even at the point that there are words in my own circle that I will not allow, I'd ask people not to say, because for me, they're very negative words. And I choose what I hear in my environment. I choose what I say to myself. So I agree. We all need to take that step back and self-analyze, self-assess. I don't even like the word analyze. Self-assess first. Observe what's around you. Observe how you behave. And that then leads into how maybe your company can behave, especially if you're a small business owner or even a large business owner. Many years ago, I had a client when I was in Ohio, and the CEO of a major construction company never, even though he had access in the parking garage to go to his top floor office, he would take the elevator all the way down, come into the street, go up the elevator, and walk in the front door at 7:45 every morning like clockwork. He wanted to see the first line of defense was his receptionist. She was one of the higher paid people in his company, because he knew that every one of his construction clients that walked in that door needed to see her, needed to be served. And he taught so many people how that's where you start. That was one of the best assessments. And I think that's where I learned so much, that I'm really, I do pay attention to what happens. And of course, with what I do, yeah, I have to. But I think we all need to just be in the moment, the present, and try to understand what's going on as we move ahead. What does it do? It decreases our drama, and it gives us more information about the world around us, the people that we're working with, our friends, our neighbors, and even our kids. The one area that I find is when I say to parents, breathe, smile, laugh, take a step back. And it's like, well, you don't understand. Well, it's the same no matter what or where. We go through the same kind of drama and trauma. It just impacts us differently, because the trauma in our lives may be here or there, but it's still impacting our emotional and our mental health. Speaking of which, what steps do you guys think we need to develop that we can help create a more trauma-informed care community? We've talked about this for so many months and years, and the coalition, our goal was education. But is there anything that your agency is doing, or that you see we need, that maybe I'm not aware of as, mental health coalition director? Any thoughts?
Well, I know in NAMI, we don't discriminate, for one thing, because a mental health condition can affect any race, any age, any economic background. It's non-discriminatory. So you want to make sure that you're in your community, that you are representative of the community that you're serving. When you come into the office, are you greeted with a smile? Is there a language barrier? Is there information, like we just celebrated AAIS, which is Asian American Islander Month. And so is that available? Did you say hello? Did you recognize and say, hey, you know, I'm glad this, we're recognizing that. Is your organization really inclusive? Do you have people that look like me that's in your organization? So I think, you know, you have to, like Jeremy said earlier, assess your whole organization to make sure it's culturally competent, inclusive. Are they going from the point where you want the person to feel safe? Things like that.
And I think piggybacking off of that, Ida, a lot of us in our different organizations, I know at Lifelines, we are very aware of like how we interact with our coworkers. And I feel like we all kind of represent what trauma-informed care is supposed to be. But sometimes when we do those referrals, I see a lot of people in the hospital system. The hospital system has been known to be relatively traumatizing, especially if you've experienced some kind of past trauma. So I think really working with those outside agencies to give them the tools of trauma-informed care and how they can better interact with our clients and our survivors, so that way when we are doing these referrals, it's a community of trauma-informed care providers, and it's not, you come here and we're very trauma aware, but all these other outside agencies we may be referring you to may not be as well. So I think really having a community is what really is going to kind of complete the circle of trauma care.
Right. You're speaking toward continuity of care. Once you finish with this organization, if I've done what I can do, and then I'm transferring you to another, and you're right, that is very key.
I think when we started the coalition, that was one of our goals, was inclusivity. We wanted to make sure that we had organizations who were at every conference represented a different group. We were inclusive of certain audiences. And I know we missed, because of funding and capability, sometimes we missed our hearing impaired and our blind population. We knew that. But we also knew that we struggled with, we had to start somewhere. And I think that's what people forget. Start somewhere in your assessment and know that you can't reach all the people all the time, and you do the best you can do. But that doesn't mean that you did not include them at some point in your plan of action to reach them during that education process. So we have to look at that. And Kat, I agree with you. I think nothing is worse sometimes than going into the hospital and they tell you that the reason that you are STRESS, that's a word I don't like, because you're in the hospital. Well, you've already now language-wise just set that patient up and that consumer up to be in that position, because you put that thought into their universe, in their mind. And I think also we have to look at what do we say to ourselves? What do we say to others? And language is important, even in trauma-informed care. So that we could do a whole discussion around that. And we're going to move on here to the second question, which kind of leads into that. Kat, you talked about advocacy. You were right. We have to advocate for ourselves. And we also then look at advocacy and teaching and empowering the consumers that we serve, especially our staff and our personnel, to advocate for those who cannot speak up or who have not the opportunity to speak for themselves. Advocacy, as we know, is the action of speaking up for those who cannot speak for themselves. They have their needs considered and met by those around them, and empowering them to feel more independent in their own life and care choices. Share with us your perspective on advocacy and how you and or your agency can increase advocacy within our community, or how you have done that. Please do share a positive and any challenges that you see that we are missing.
I think, at least like speaking for Lifelines, I think the model that's been created when it comes to sexual assault, especially when they're coming in to receive a medical exam from that sexual assault, is really focused on advocating for that patient. Not only do we have an amazing group of 8 forensically trained nurse specialists that will come and see these patients 24 hours a day, but we also have advocates that will come in and sit with them. So you not only have your nurse advocating for you, but you also have a separate person that can be there for you in that moment. to kind of walk you through the next steps. So we're not only focusing on medical, but we're bringing in that mental health component, which I think is really important. And then it kind of segues to how else can we advocate for you outside of this room, outside of this exam room, because we know that, you know, sexual violence and domestic violence don't tend to happen in a cyclone. There's normally other contributing factors. So we really take on them, not, sorry, my dog's barking, take on them not only in that moment, but from kind of going from victim to survivor.
One of the pillars of NAMI, of what we provide is advocacy, self-advocacy and advocacy with our legislature, advocacy and making sure that we're doing the research so that we have best practice medication, best practice treatments available for individuals who are dealing with a mental health crisis. One of the things that we advocated for was getting change to the commitment law here in Alabama, across the state, so that people can have better access in getting treatment. Another thing that was very good for us here in Mobile is we advocated so that we could have a crisis center here where a person could be seen. And I hope you all are aware, Dr. Cindy Gibson is the program organizer of the Crisis Center, which is located on Gordon Smith Drive. And it's designed so that a person can come voluntarily, come in, get stabilized, you know, and then leave. So, you know, we're trying to have, and the 988, we all need to advocate and talk to our legislators that make sure that we have money so that the 988 can be a point of contact for individuals with a substance abuse or mental health crisis. So if we don't get the funding, then that's going to be nil and point. So make sure that you're doing your self-advocacy so that we can have a true operational 988.
Jeremy, VRR consumers have already been traumatized from life experiences as veterans. So they come with probably more types of trauma than others see. I'm just saying from the military, maybe or maybe not, military war trauma can take a different impact on the people who serve simply because in the time that they served, or even now, they may have been forgotten. And some of them were, as we look back through history. How does VRR take approach to helping them advocate and learn about advocating for themselves, but also building your team, like Kat says, she's got, you know, she's got the medical and the court system and the mental health advocates with their consumers. What does VRR help, and how do they help their consumers?
Yeah, so I think there's a couple things in that question that that's a great question. And thanks for asking that, Cher. I think there's a couple things I would like to highlight there. One is the word consumers. I know that a lot of us have to use that word because of our grant programs, and we really like to use that word. I don't think that's an accurate reflection of someone who is suffering.
Right.
And so, you know, for us, I really like to make those distinctions between pain and suffering, and feel like our role within our medical system is to reduce human suffering, whether that's mental, emotional, or often spiritual distress, whatever the case may be. We seek to reduce human suffering. We also know that it's pretty, you know, life is gonna provide most of us some type of experience that could be classified as a traumatic experience. It's then considered, you know, what are the effects of that experience that then, you know, go on to think about, like you're talking about within the veteran culture. Sometimes there are people that perceive and understand that, hey, veterans are exposed to these things, but I'll tell you what, if you live in Mobile, where our clinic is located, and you see the gun violence that's happened with our community, it's as much as a war zone there as it is in a combat zone. So even in our own community, we have probably the equivalent of what some may consider to be a a combat zone and what the effects of those traumatic experiences may be. I think the value that we have to offer there is, I think, one, to realize, and this is a component of trauma-informed care, that, just because you're exposed to traumatic experiences does not mean that your pathway to recovery from those traumatic experiences are a PTSD, right? So resilience is actually what most people's general response is. Usually it's very low percentage of people that go on to get a diagnosis of PTSD. So realizing that we really have this inherent capacity to endure difficult times is a part of our humanity. We do that best within a community of people, though, right? So we do that best whenever other people within our community are coming to us and seeing the suffering that we have, and they're willing to render aid to us. And so I think those are the things that we've found that we want to provide a value to our community, is that, one, to destigmatize seeking help, right? Veterans really are terrible about it. And so I think that's one thing that makes us a little unique, is that most of the people in our organization, including myself and our founder and many others, we have a lived experience. So we have some experience in mental health or substance abuse, and I think that's of real value, because we've walked the walk, we've talked the talk, we've been there, we've done that, and also realize how challenging it is to go through that type of recovery process. So that, in essence, is where I feel like the peer support component of recovery is critical, because in essence, what we also know is that recovery is dependent on relationships, and we have to have trusting relationships to recover. So when we're isolated, we're not able to build trusting relationships with others, we're more vulnerable. And I think those are things that, we want to create a community of people who are in recovery, so that they can share their experiences together. So I think those are the ways in which we're trying to address some of these more systemic challenges like you were talking about.
I think that you brought up destigmatizing, asking for help, but more importantly, destigmatizing the issue of mental illness. When we, and thank you for talking about consumer. I use that word when I'm facilitating, because there are so many other words out there that I'll get a call and say, that's not who I serve. So consumer, you define it, but I like community of people, because we all serve people. And yet on a day-to-day basis, there are so many things that you're right about. The gun violence is a war zone, and it's a domestic war zone versus another, international war zone where someone else is. But you're right, it's truly a war zone. Wherever there is that kind of violence, it's a war zone. But I think what I see within our community, and I know that, United Way covers like 8 or 9 counties, but we all cover the world in essence anymore with social media. And with the use of the internet now, we have technological access to so much more. But when we focus on change, as an advocate, I find there are 2 types of advocates: those who want to change the world and, change everybody, make everybody happy. And that's great. But until you change yourself and you understand that you've got to heal. Families of gun violence, the first thing I find with people I've talked to, they want to help others, but they haven't healed. And it's important that they heal first and understand that healing, so they can then give to the communities. And sometimes I think our community, we're lacking some empathy. Maybe it's just me, but I see a lot, I observe, and I sometimes hear in conversation, people want to blame another organization, another individual for the way things are. But there's this lack of distrust, or there's distrust and lack of trust somewhere in our communities between the agencies, the businesses, just a general people culture, education, government. And it's almost like we're in a disconnect. Any thoughts from the panel on my observation.
Well, I think you made a good point, Cher. And I think just speaking from like a medical standpoint, coming out of COVID and kind of getting back into what nursing and medicine looked like beforehand. Because I think everybody kind of got beaten down. Bedside manner was not the best because you were trying to limit contact, and just the mass amount of people we were seeing, you kind of lost your bedside. And so now we're kind of getting in to what it's like to hold conversations with people and to work on being better advocates in general. So I think this is kind of, as horrible as COVID was, is a good time to kind of bring the issue up of we need to work on how to better advocate for our patients, how to better advocate for ourselves so that we understand and we can take care of others. Because I think that was very much highlighted through COVID, is we weren't taking care of ourselves. And you can see that in the way that we were interacting with patients.
Oh, self-care was probably the first, or lack of self-care was one of the first behaviors that I saw from so many people. You saw it from parents who didn't have a relationship with their kids and the school system. You saw it with families who were in the same room, in the same, on the same space of ground, but they hadn't been. And they were forced into that, oh, I need to get to know you. I may not like you at the end of the time, but we're here together. And yet it brought about more negative illnesses or negative choices and depression. And we had, suicide ideology was up, crime was up, that those negative thoughts were up, which is a language of self-talk and talking to ourselves. So we weren't listening to what we were saying to ourselves because there was somebody on each side of us that was hearing what we were saying to ourselves, and they were taking it to mean to them. So I think we've got a lot of work to do in order to bring our community back to where, when I moved here 20 years ago, it was a happier time. It was a happier place. People would talk to each other. What is it that, is there one thing that each of you can give to our audience as to what they might be able to do in order to help be a more effective advocate, but also not redo the same mistake or the same choice that we did before in the forced advocacy? You have to do this, otherwise this is going to happen.
Well, I think Catherine and Jeremy kind of already spoke on it, but the pandemic itself was a trauma. It was a global trauma. And to be honest, there are still some people who are affected by that trauma. Mm-hmm. And I think sometimes you have to give yourself grace. I mean, you have to, say, hey, it was a blessing that I even woke up this morning. You have to start, counting the little things that lead to the bigger things. And, self-assessment, knowing where you are, what your view is, because trauma affects your view of self, your view of the world, and your view of the future based on your experience. And so I think one of the big things is we have to give ourselves grace.
I couldn't say it any better, Ida. I think that is a micro step. If you're not giving yourself grace today, take to heart what I just said, and each of us on the panel and the participants, just breathe in and say, it's okay. I'm okay. I'm awesome. And give yourself that grace to know that you came through it, and you may still be going through it, because you're right. There are so many areas of the pandemic that we haven't, that keep unwinding and unraveling every time we turn around. There's a new health issue, there's a new health scare, there's a new mandate coming out, and then there's not a mandate. So we're still in this confusion of how do we live every day, and what do we do as individuals in that family unit, or even in a single unit, whoever your family is, however you identify it, so that we can become healthier. And that's why mental health is really important. I find myself laughing more now. I probably laugh sometimes inappropriately at things that I shouldn't have, but I'm sorry. I'm 71. I have my permission to do that. That's where my grace comes in. But it gets down to and brings us into the next topic is that equitable access to mental health care. Equal access should mean every person has access to preventive, promotive, and curative mental health services. What do each of you feel are some of the barriers in this community with that community of people that are keeping this community from providing equitable mental health care? I know, powerful question. Any thoughts?
Sure, I like powerful questions. And that's a great question. I think you asked the question of equity. And yeah, I think equitable distribution of resources is included in that. Equitable access is included in that. But there's also, I think the panel discussion or the title here was diversity, equity, and inclusion. And what I've seen in terms of equity in healthcare and achieving health outcomes across a community or given a set of people is, addressing and many of you have probably heard this term, I'm sure, social determinants of health. So I don't think we can address like a community level's ability to deliver equitable care across a community without first understanding the impact of disparities in social determinants of health. So that the differences in outcomes are highly related to, our zip code more often than they are, what level of access we have to a particular care provider. So if we kind of take the work from Robert Wood Johnson Foundation and look at what they've described in their sort of theoretical framework that they've operationalized really well, somewhere between 50 to 60% of health outcomes are related to these social determinants of health. So in that way, there really isn't anything that we have in a community that does not in some way influence someone's health outcomes.
That's correct.
So whether that is politics, whether that is our school systems, codes that we operate by from the infrastructure level, all the way down to really, really basic resources that we have. Each one of those has some type of implication with which we live in an environment that's going to determine whether or not we're going to live well. And so that then becomes our collective issue together, is how do we want to choose to live together? How do we want to advance this idea of well-being and collective well-being together? So those are kind of the things that I've seen. Now, there are many topics that I believe are under-discussed in the realm of equity. Racism is one of those topics I think that's under-discussed and not talked frequently enough. I know with our organization, we look at how right now, we're in the middle of trying to submit a grant to increase access to Black and African American community members. And I know distinctly there are reasons why that people don't trust medical systems within those communities. And so how do we address that? As a community, how do we go about addressing that? And I know we have some people in our community that are doing great work in those areas already. So then it becomes, pulling those folks together and saying, hey, let's continue this collective work together. So it's conversations like these too that really help advance equity as well. So I'm glad I'm here for this conversation as well.
How do each of you answer the question? It's one I hear multiple times during the day, or I might hear a side conversation when they say, when the statement is, there's not enough mental health community resources in this community. I can't get mental health, I can't get help because I don't have insurance. I know this is a loaded question, but it's a question that frequently, if not every day, it's on social media, somebody writes about it, and then you have a whole list of people who respond, positive or negative. And yet I know that we have counselors and therapists who are always looking for new clients. We have places that are needing more community of people to come be a part of, to seek the help. How do we, what do you say to that person? How do you answer that question? And then is there something that we can do to help educate them more? Or what are we missing that we're not getting the message across? Thoughts?
Sherry, can you clarify that question one more time for me?
Okay. Every day somebody says or writes, City of Mobile or the county or the area doesn't have enough mental health services. I am not able to get service because I have no insurance. I'm poor. It's not in my community. And some of them want it within, walking distance, but not every zip code has a service, but we have services. How do you answer that question and help them find that trust, Jeremy, to understand that we do have services? But the public seems to think they're not there for them.
Sure. Yeah, no, I definitely understand that. And I've been a part of a few of those groups too. And I mean, from my perspective, the things that I've seen have been the biggest barriers to accessing care. And that's kind of how I conceptualize this question is what are the barriers? What are the things that are keeping people from getting to a particular service or, leading a life that is living well. So in that kind of understanding of barriers, there is a stigma that is associated with seeking care for mental health. And that is that, when we think about stigma, there's perceptions, there's beliefs, and there's attitudes. So how do we begin to shift perceptions, beliefs, and attitudes? Is that happens within the context of a relationship and getting to know somebody, being open and honest about who you are and being open and willing to listen to someone else's experiences. So I think within the context of an individual relationship, we can really begin to shift ideas, beliefs, and attitudes about seeking care, which I feel like is a major barrier. Then there is a community perception too. So that not just the individual, but the community at large has a perception as well. So, what are those community perceptions? I know in some of the work we've done, we've looked and said, how do you how do you understand mental health? And there's varying degrees in what people understand mental health to be. So I think that's another opportunity to address stigma. And then we have, those are perceptive barriers, but then we also have very practical barriers. So, and I would add really one more to the perceptive part, but that is trust. Trust in the outcome or trust in what's going to happen if and when I access this system, I think is pretty fundamental. I have friends that call me and talk with me about this, and regardless of where they are on the socioeconomic scale or ladder, they all have that same fundamental belief or question of what's going to happen when I go to this place. So I feel like, and that could be addressed through marketing and communications and other ways that we can think about how do we answer that fundamental question that people ask of what's going to happen whenever I go in there, right? Because people are still living with perceptions of institutionalization for mental health conditions. That people are still these ideas in the community are pretty still prevalent. So I think that's another area. And then then there's a whole litany of different practical barriers that people have: lack of transportation, lack of money, lack of funding, all the lacks of. Right. And I think that is what people feel, and they experience that on a real daily basis.
But also, Jeremy, I think as a community, we don't do a good enough job of talking about the services that we do have, the resources that we do have. Where can you go for this? Where can you go for that? Collectively talking about where, you know, things are. And maybe, wouldn't it be nice if you had an urgent care in every community that had mental health access, doctor access, this access, you know, where you didn't have to go everywhere?
Yeah.
That would be great, ideally. I
And I
mean,
think
we got to talk about what resources do we have? All right, where do you go for this? Is there one place that I can go to? Okay, I'm new to Mobile. I need to know da 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 da. Who are the doctors that are serving this? What are the doctors that's, you know, working with this? What agencies are doing this? You know, what is available in Mobile?
I
Right.
think it's also too about us understanding, not only like Ida said, what those resources are, but getting together as community partners to almost kind of validate your patient of saying, or your consumer or your victim survivor of saying, hey, I'm going to send you to go see Ida. Ida's lovely. She's going to do this, that for you, to kind of build that relationship of kind of like, I call it a Yelp review. People are a lot more willing to come see me in the hospital if the advocate says, oh, I know Nurse Kat, she's going to take really good care of you. So having that continuity of care of saying, I'm going to let you go to this agency, but this is someone that I trust. So it's less of, well, what are they going to do with that scary building? Because I've already built a relationship with them. So that relationship can then go to Ida so that, you know, they're more willing to go out and receive that care because they feel like there's some trust and that relationship's already built. So I think building off of the rapport that we get already is really important to continue and get them to seek other services.
That was one of the outcomes that came out of our last conference for the coalition. And so in March, we started, along with Alliance Healthcare, a luncheon just for mental health professional. It's not about where you work. It goes back to what you said, Kat and Jeremy. It's about the trust. Who are you as a person? The more that I know about someone, and it's what you said, Kat, you know, Ida's a great person. She's cheerful. She'll do well. You know, I know her. She will do well with you. And here's, you know, you get that referral or that recommendation, that blessing from you to her, to your person, your patient or your client. And it makes all the difference in how they will go to Ida and perceive the service that she can offer to them. And I think that's why, as a mental health profession, instead of seeing, we all see the same people, because all of us on this call, I was noticing as they were chiming in, we're getting a lot of resources in the chat area. So when you listen to the replay, write down, get a piece of paper and write down what people are responding, because they are responding and giving information. But more importantly, make it a point of talking to someone every day. If there's someone that you know you give referrals to and they help with your clients every day, send them a thank you. Pick up the phone and say, hey, I would love to have a cup of coffee with you if you don't have time, but thank you for what you're doing. The kindness that we as mental health professionals can give to each other goes a long way in helping us become more empathetic and more encouraging and empowering to the people we serve. One of the things that I know is we have free transportation in the city of Mobile for seniors. We have 211, someone mentioned. That is my to-go, 211. But what I'm finding is you have to explain to people how to use effectively 211, what you need to ask them, not just your zip code. So again, it's what information are we giving to the people we're serving that's going to help them to understand how to move through. And I know with a couple of the families I've worked with, it's literally sitting down that plan of action in a phone call, finding out where they are, and attacking each, you know, finding a resource and a solution or a path to the 3 or 4 things that they're having issues with. And it may be, I need a will. My family member has been, you know, has now been committed, but I need to understand. I need to understand the court system. I may not know, but I need to know the resource so that I can share that with them. That's empowering. And I think sometimes we don't even do that within our own community. So the more we get to know each other, I think the more we have to share with our consumers. We're kind of out of time. Trista, do we have any questions?
That's what I was just going to share. We have several great comments and one request from Brad Martin to go back to the empathy conversation in our community. He's just shared that he's encountered some of the same things of people quickly judging others in situations. And then there was a request for mental health resources for Spanish speakers. But I think that was addressed with some information.
Okay. Thank you for all of you who have participated by your comments. I've been trying to watch them. I'm on my cell phone and I can't type. I can air type and that's about it. But thank you for participating, and thanks to our panelists, Ida, Jeremy, and Kat. And thank you, Trista, for bringing mental health awareness in the DEI form. You know, we've talked about it in a way, we're not using the words diversity, but we've talked about it as a whole because we are a whole community, accepting of each other, where we are, no matter what we look like, no matter who we are, and we are here to help. So as you guys go, as the participants go through, as anyone listening to this, if you need any assistance, make sure you call 211 Connect Alabama so you can find resources for whatever your needs are. If you feel that you're in crisis, dial 911 or dial 988 and know that there is help at the other end of the line. And all of us here are here to help. And so I will leave you with my best affirmation, and that is breathe, laugh, and smile. Repeat when needed, because your mental health impacts our mental health, and how we feel impacts the service that we provide to each of you. We are here for you. We thank United Way of Southwest Alabama for helping us talk about this. And I also, somebody said we were talking about education, and I kind of got a little, I don't know, nudge on my shoulder that said, aha, it means that we're now due for a mental health conference in the fall. So make it your agenda to help, because I know we will be putting a mental health conference together. Jeremy, you mentioned 3 things: perception, belief, and attitudes. That may be the focus of our conference in the fall, because I think it's desperately a topic we need to address to bring more empathy and more caring and kindness into our community. I'm Cheryl Graham, and thank you for joining us today. I now turn it back to Trista.
Wonderful. Thank you, Cher. We do have a quick poll that I'll launch in a moment, but I wanted to see if our panelists had any final thoughts or affirmations that they'd like to share with the group before I do that.
Just thank you all for hosting this for us. This is great. Appreciate it. Thank you guys. Thanks, Cher. Thanks, Trista.
Kat, Ida?
Hi. Okay. Again, thank you so much for the inviting me to be a panel guest. I hope that everyone has a wonderful rest of the week. And you can always get free information at NAMI.org. We have a wealth of information, education on any kind of mental health condition that there is. Everything is free. So when I start talking about the walk, y'all need to sign up. Also, we hope to have soon a family-to-family class in the fall, and our movie that we do for the community in September. So be on the lookout for that.
Thank you guys for letting me be a part of this. Thanks for the invite.
Thank you, everyone.
All right, I'm launching the poll, and then also this will be recorded and featured on our United Way YouTube page. So feel free to connect your network, colleagues, family members, whoever you feel like would benefit from watching the session. Everyone, enjoy your weekend, and thank you again for taking time out of your afternoon to be with us. Bye.